management of heart failure with reduced ejection fraction, and the indication of SGLT2 inhibitor, and practically they are same. For ARNI, you say less than 40%, class 2 to 4, and it can be administered in conjunction with the background of optimal medical therapy, and same indication is with now with SGLT2 ejection fraction less than 40, class 2 to class 4, administered in combination with the background of GBM for heart failure. So now the indication of adding SGLT2 has become equal to ARNI management of heart failure with reduced EF. And these are the contraindication. I think the only few contraindication when you type 1 diabetes, you should not give. No hypersensitivity to this drug, you should not give. Lactating and pregnant women, the data is on dialysis, you should not give this DAPA in patient of heart failure with reduced EF. As far as the warning and precaution is concerned, I think for Dapagliflozin supposed to be more safe in renal dysfunction as compared to the DAPA. Rest all, I don't think there is much difference between these three drugs. So it is proposed that a conventional sequence of management of heart failure with reduced EF, ACE inhibitors, beta blocker, then you add MRA, then you add, if the patient is not stabilized with ACE inhibitor, you can substitute ACE inhibitor with ARNI, and then SGLT2. But the few authors are very aggressive. They say no, start this because majority of the patients of heart failure are either diabetic or a pre-diabetic. Then you can start it as a first-line drug with beta blocker, ACE inhibitor, and SGLT2 inhibitors. So the SGLT2 inhibitors has opened a new era in management of the heart failure. When added to standard therapy, DAPA reduces the risk of worsening heart failure events and cardiovascular death. Patient with reduced EF, the relative and absolute risk reduction in death and hospitalization were substantial, clinically important, and consistent in patients with and without diabetes. DAPA was well tolerated, and the rate of treatment discontinuation was low, both in diabetic and non-diabetic. DAPA offer a new approach to the treatment of heart failure with reduced EF in patients with or without diabetes. Thank you very much for your time.
Thank you, Rakesh, for that updating us on the role of SGLT2 in heart failure. As you said, none of us, this would be possibly for the first time that when the FDA said in May 2020 that a drug developed to treat diabetes can be used in heart failure with or without diabetes. Now, that is very interesting, and as you have shown most of the data, we are getting more and more areas. The last but one slide again, you showed where to put it. The fantastic 4, beta blocker, MRA, ARNI, and CLT2, how to sequence it. These are areas where possibly we can have an interesting discussion. We will have the second talk also to come, and may I have the pleasure of inviting Professor Banerjee for his talk on the importance of heart rate. I think every one of us are aware how important heart rate is in the eventualities that happens in heart failure, both in the genesis of its mortality and otherwise. So, Professor Banerjee, please.
So, good evening, everybody, and welcome to the City of Joy. Our President, Dr. Mohanan, and all of the respected DC members, dear friends. So, my task is to discuss the role of beta blocker in the management of heart failure in reduced ejection fraction. Now, you all know that this is an age-old drug, beta blocker, and is being called as reverse remodeling drug. So, there is no controversy of using beta blocker in the management of heart failure with reduced ejection fraction. But now the concept has come in whether you can combine a newer molecule, ivabradine, with beta blocker in the management of heart failure, where the patient cannot tolerate the recommended dose of beta blocker because of the various side effects or contraindication. Now, we all know that the heart rate is one of the most ominous signs, particularly the resting heart rate, in the outcome of the heart failure with reduced ejection fraction. So, if you cannot achieve the basic heart rate in the rest below 70, you don't get the outcome benefit. And to achieve that, beta blocker is definitely a major drug, particularly the beta-1 receptor blocker like metoprolol, carvedilol, and the bisoprolol. Now the question is that many patients do not tolerate the target dose, or when you try to up-titrate the dose of beta blocker, several side effects come in, and obviously you have to restrict the dose, and then you have to think of another molecule which is having beta blocker like effect, but doesn't got much any compromise in the hemodynamics of the heart, like the blood pressure, cardiac output, etc. So thereby initially, when the patient comes, we first start with the beta blocker and other drugs already being discussed like MRA, ACE inhibitor or RD, and finally what Dr. Jadhav has already said about the SGLT2 inhibitor. And even then the patient's resting heart rate is going high, then you think of using a new molecule, evaporated, you already know that, being used for a quite long time, which is IF channel inhibitor, acting on the SA node and not causing significant bradycardia, and also does not have any effect on the cardiac hemodynamics. Now this is the energy lost because of the continuous beating of the heart, almost 300 milligram of ATP per beat and 30 kg of ATP per day. So heart rate reduction by 10 beats saves 5 kg of ATP per day. So the main target is to reduce the heart rate to below the 70 rate, but not below the rate of 50, because that will be associated with other side effects. Now the prospective study has shows the primary composite endpoint as you going below the bradycardia side or lowering the heart rate. And if you compare when the heart rate is more than 87 as opposed to when it is less than 70 or 72, the primary composite endpoint also progressively decreases. So thereby lesser the heart rate, less is the chance of worse outcome from the heart failure with reduced ejection fraction. Now is it a risk factor or is it a marker? Now the slide shows that it is more of a risk factor. Now as there is an increase in the heart rate, that will lead to situation of chronic heart failure because of the tachycardia-induced myopathy, you all know that, and there is increase in the oxygen demand. There is a ventricular inefficiency because of the reduction in the filling time, so automatically the stroke volume will reduce, and thereby ultimately patient will go into the chronic heart failure because of persistent tachycardia. And there is also some comorbidity problem like microalbuminuria, that is remodeling of the heart, there is a cardiac hypertrophy, and because of the increased heart rate, as you know, there is a demand-supply imbalance, and there is chance of ischemia, and reduced diastole lead to decrease in the coronary perfusion. And finally, there is increased rate of atherosclerosis because of the oxidative stress, because of the flux instability, and because of the arterial stiffness. So all these factors are considered as the risk factors for various numerous things that I already mentioned. So thereby, the idea is to reduce the heart rate, and thereby you prevent chronic heart failure, comorbidity, remodeling, ischemia, and atherosclerosis. Now, when you are not being able to reduce the heart rate to the target level, obviously then you have to choose another molecule, and that is called ivabradine, which is IF channel inhibitor, acting on the SA node, and thereby reducing the heart rate and helps in titrating the dose of the beta blocker, or also help in reducing the side effect of the beta blocker when being used in combination. Now we all know that beta blockers, there are three mainly used, and there is no much difference between the carvedilol or metoprolol or bisoprolol. All those have definitely the mortality reduction and anti-remodeling effect. So thereby, choice of beta blocker is your experience and you are comfortable with, and these are the various beta blocker trials like Medit heart failure, CBIS2, and the Copernicus using the metoprolol, the bisoprolol and carvedilol. More or less they are having the similar results, the relative risk reduction varying from 34 to 35%. So there is no much difference in reduction of the mortality rate. Now what is the difference between these three molecules? All of them are beta-1 receptor blocker, but the carvedilol has additional beta-2 blockade effect, and it also causes alpha blocking effect, and there are no effect on the ISA by all three these beta blocker. Only ancillary benefit by the carvedilol is that it has got antioxidant, anti-endothelin, and anti-proliferative effect. So that is the only difference with the other beta blockers. So thereby, when metoprolol is compared with the carvedilol and in the COMET study, and as the days progresses, the length of therapy increases, and they have shown that there is divergence of the curve as you continue to treat with these two molecules in terms of reduction in the mortality, and that is definitely a beneficial in favor of this carvedilol as compared to the metoprolol. Similarly, the onset of new diabetes also you can see as you continue treatment with these two molecules, there is again divergence of the curve, and incidence of diabetes has seen to be more with the metoprolol as compared to the carvedilol. Now coming to the heart rate reduction, when you achieve a heart rate of 70 or less than 70, and you can see the annual mortality rate also progressively diminishes. So thereby the bottom line of the fact is that the reduction of the heart rate, that particularly the resting heart rate below 70, has to be achieved without any side effect of the titrating after taking dose of the beta blocker. But if you come across with that effect, then you have to consider this new molecule, that is ivermectin, which is a IF inhibitor and acting on the sinus node, and thereby there is a key determinant of the heart rate, SA node, and ivermectin reduces the diastolic depolarization slope. And the advantage of ivermectin is that it does not cause any effect on the cardiac hemodynamics like the systolic blood pressure or the cardiac output. And mean heart rate reduction, as you compare the placebo with the ivermectin, there, as you can see, there is no much significant difference between the heart rate of different doses of ivermectin. So thereby, there is no fear of producing significant bradycardia as you uptitrate the dose of ivermectin. Now coming to the effect of the composite endpoint reduction again, when it is compared with the placebo, and as you can find out that the cumulative frequency of the composite endpoint reduction was by 18% in favor of ivermectin when it is compared with the placebo. What can we achieve to target the heart rate? Again, it is the slide showing that greater the rate and more is the chance of primary composite endpoint. So again, showing the result that this is from the SHIFT trial, that if you can reduce the heart rate between the 60 to 70, the primary composite endpoint also comes down, and that has been shown from the day 28 onwards that progressively the patient heart rate becomes stabilized to the tune of 60 to 70, the primary composite endpoints comes down. Now, as regards the other outcome like the cardiovascular mortality, hospitalization of the worsening heart failure, death from heart failure, all-cause mortality, all-cause hospitalization, and any cardiovascular hospitalization, all are in favor of ivermectin, and as when you achieve the target heart rate. So the question is now, is it possible to combine the ivermectin with the other beta blocker, particularly which is now recently being marketed with the carvedilol? Now, if you consider the contraction and relaxation in heart failure with reduced ejection fraction, as you can see that there is compared with the normal situation, and there is a reduction in the contraction, and also there is a prolonged relaxation period. So that will ultimately affect the cardiac output. And the pathophysiology is that in the heart rate reduction associated with increased performance. So when the contraction is reduced, the filling is also less, the stroke volume is also less. But when you reduce the heart rate, the diastolic filling period is more, and that there will be more cardiac output, and the whole hemodynamics also changes. The short-term effect of ivermectin on the LV function, as it shows, when you look at around 4 hours of therapy, the heart rate is reduced by 27%, stroke volume is increased by 51%, and there is a neutral effect on the cardiac index. And that is the advantage of ivermectin over the other beta blockers. The short and long-term hemodynamic effects of the beta blocker varies, and you can see the left ventricular ejection fraction when the metoprolol is compared with the standard therapy. Now, initially there is no much increase in the ejection fraction. Now, as you continue to follow the treatment with the guideline-directed therapy, look at the 3-month result, there is a significant improvement in the left ventricular ejection fraction as compared to the early therapy. So, longer the duration